6 months, right? Schizophreniform is when you have the symptoms more than 1 month, but less than 6 months. And brief psychotic disorder is when you have more than 1 day and less than 1 month. So how does this work out? Typically, the people who have brief psychotic disorder, typically maybe something happened to them here. Doesn't have to have, but probably something happened. And as a result of that, you develop psychotic symptoms. I give you medications, I give you antipsychotics, and chances are you will return back to what's considered normal. People who have schizophreniform will probably also return back to normal. However, the people who have schizophrenia, it's very hard for them. So this is like a big wall. It's very hard for them to return back to normal. So once you pass this line, it's hard to get out. So once you have that schizophrenia, that's it. There's no turning back. And it's harder for you to return to what's called your pre-morbid level of functioning. So the person who had brief psychotic disorder, 15 years from now, they can have another episode. The person who had schizophreniform, 4 years from now, they can have another episode. But the person who has schizophrenia immediately stays with the diagnosis of schizophrenia, and you will have the disorder for the rest of your life. Does that make sense for everybody? All right, good. So what is important for you on the exam, for you to have the diagnosis of schizophrenia, I don't want you to worry about time. I don't want you to look at a question and say, oh my God, there's no time on there. It cannot be schizophrenia, because it can. Look at the symptoms. Time is important in brief psychotic and schizophreniform, because how do you differentiate brief psychotic from schizophrenic? Duration of symptoms. How do you differentiate schizophrenia from schizophrenic? Duration of symptoms. So for brief psychotic and schizophreniform to be correct, look for time. If it's not there, do not give it as an answer. Okay? Does that make sense to everybody? Time is crucial in how we make these diagnoses. Are schizophrenia and schizophrenia, are they different? They can be a continuum. They can be. They don't have to be. So you can have a person who develops symptoms here. 1 month goes by. They're now called schizophreniform. 7 months go by, and now they're called schizophrenics. Or you can have a person who develops symptoms. 2 months later, their symptoms are done. And that would be schizophreniform. So it can either be on the continuum or doesn't have to be on the continuum. And all three of them get antipsychotic medications, correct. All right, so let's go back to the diagnoses. Let's go back to the slides. Can we treat schizophreniform and prevent them from developing schizophrenia? You know, I think that if you're going to get it, you're going to get it. And if it's in your genes to get it, it's going to happen. So I don't think you can necessarily prevent it. So let me get some color here. Hold on. Let's use a different color. I always use pink. Let's use... Oh, so much for choices. Here, let's use orange. A 35, when they go back to normal, can they stop meds? Yes. Red, you want red? Let's see. It's hard to see what red is. I mean, I think this might be red. Oh, wait, this is like brick red. There we go. A 35-year-old Chinese immigrant is brought in by neighbors. Let me make it thicker. Hold on. After she was found wandering in the streets yelling out someone's name. She appears disheveled. Remember, clue? She's disoriented. She arrived in the U.S. several days ago and upon her arrival witnessed the death of her 3-year-old son. While in the waiting room, she's responding to internal stimuli. When you see that, it means that they have auditory hallucinations. So they're listening to voices. So what is this diagnosis? It's brief psychotic disorder. Why? Because we know that it's more than one day, but less than 30 days. So these individuals can have hallucinations, delusions, disorganized speech, any kind of symptoms, but this is what's important. More than one day, but less than 30, and of course, you treat her with an antipsychotic. We are going out of order. Let me go to this one first, okay? Does it have to have an acute stressor? When DSM-3 became DSM-4, they removed the stressor part, so it doesn't have to have it, but it usually does, if that makes sense. Mrs. Jones is evaluated at a nearby clinic after she was acting inappropriately at work. According to her coworkers, she began acting strangely 3 months ago. She was wearing a hard hat to work, and when asked why, she replied, "I will not let you read my mind." She also believed that others were talking about her. She had to be escorted out of the room because she started to argue with others whom she believed were controlling her mind. So we have this theme of paranoia, but it's been going on for 3 months. So what do you think the diagnosis is? Because it's more than 1 month and less than 3 months, we know that it is schizophreniform disorder. And how do we treat antipsychotic medication? Does that make sense to everybody? Yes? Okay. Then we have schizoaffective disorder, which is a patient who has symptoms of schizophrenia as well as symptoms of a mood depression or bipolar. It doesn't matter. I would be very suspicious in picking schizoaffective as the correct diagnosis in the question. They tend not to be the correct answers. A 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, "I'm making it easy for others to have sex with me since I know they all want me." She states she heard a voice telling her she was irresistible and everyone wanted her. When she speaks, she cannot focus on one topic at a time and frequently jumps from one topic to another. Her mood is euphoric and her affect is labile. What's her diagnosis here? It sounds like bipolar disorder. She recounts an episode last year when she heard voices that she could not describe and believed others were following her. It's been for more than 6 months. So what do we have here? Schizophrenia. So what's the diagnosis? Schizoaffective disorder. All right. So I would be very careful. Yes, more than 50% of patients, when they have mania, can have hallucinations. So it's very common. So that is schizoaffective disorder. So let's review certain things, because you're getting a lot of questions here. Let me go to the whiteboard. I want you to think of, let me get something here. Think of things as if though it were a scale, okay? So we have a scale. Here, we're going to put the depressive symptoms. Here, we're going to put the psychotic symptoms. I don't think you have a problem differentiating schizophrenia from major depression. Is that correct? Those two are easy. I think the problem, major depression with psychosis versus schizoaffective disorder. Is that correct? That's where you probably would go, what's going on? All right, so look at the question and let's symptoms in our scale. For you to have major depression with psychosis, where the scale is going to be tipping towards. So let's review a case. The patient complains of depressed mood. Where do we put it? Here. She's not sleeping. Where do we put it? Here. She has no energy. Where do we put it? Here. She feels hopeless, helpless, guilty, worthless, doesn't enjoy life, and she's having auditory hallucinations telling her to kill herself. Where did the scale go? What's the diagnosis there? So which one of these would it be? Major depression with psychosis. This symptom is not enough for schizophrenia, is it? It's just one or two psychotic symptoms. That's major depression with psychosis. Now, let's go back to our scale. Let's put depression here. Let's put psychoses here. A patient who has depressed mood, helpless, hopeless, flat affect, poor grooming, hallucinations, loss of energy, thoughts of suicide, delusions that she's being followed. Is that major depression with psychoses, or is it schizoaffective disorder? Is it A or is it B? B. Okay? So the more the scale is equal, the more chances that it's schizoaffective. Does that make sense to everybody? Now, it's not as simple as I'm making it out to be, but for the purpose of the exam, this is what I want you to focus on. All right. So let's continue. Can I make another scale comparing BP1 and schizoaffective? Sure. Let's see. Bipolar 1 and schizoaffective, is that what you want? Bipolar 1, what type of bipolar 1 do you want? Remember, bipolar 1, they're going to give you just mood. Not sleeping, talking fast, increased libido, racing thoughts, delusions of grandeur. Is that bipolar disorder, or is that schizoaffective disorder? Is it A or is it B? That would be bipolar. If it were schizoaffective, then they would have to give you symptoms meeting schizophrenia. Does that make sense? All right. Let's go back to the slides. Then we have a disorder which is called delusional disorder. And what was a delusion? Because schizophrenia, remember, for you to be schizophrenic, how long do you have to have the symptoms? More than 6 months. All right. So Mr. Smith has been married for 10 years, and during most of those years, he believes his wife was trying to poison him to get his money. He frequently complains of stomach pains, which he believes are due to the poison in his food. His thoughts are logical and coherent. He's got no hallucinations. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does. So, is it possible for a woman to want to kill her husband for his money? What do you think? Yes. So, is this possible? It's unlikely, but it's possible. So his delusion We know that it's been going on for more than a month. That's what delusional disorder is all about. Okay? So they're usually non-bizarre delusions, 1 month, an intact level of functioning. And the way you treat it is with antipsychotic medications. So remember, how you differentiate a schizophrenic from a delusional disorder? Look at the content of the delusion and look at the level of functioning. Functioning people are delusional disorders. Schizophrenics are not functioning. Does that make sense to everybody? Yes? Okay. Let's review a few things. So we've got, I'm going to use the text box, so give me, be patient with me. So we've got 25-year-old man or male believes his wife is cheating on him. Is that A, paranoid personality disorder, or is it B, delusional disorder? Now, we haven't done the personality disorders, but I want to go over this. Actually, let me add a third in here and see schizophrenia. Okay? So these are the three things, and we're looking at one basic thing where you believe that someone is cheating on you. What I'm going to do is that I'm going to give you clues of what has to be present in the question for you to figure out which one it is, okay? There's no right answer right now because I haven't given you enough information. The difference between the paranoid personality, so if we look at functioning alone, so if we're focusing on functioning, who tends to function? Those that function will be the paranoid personality disorder and the delusional disorder. Which one is not functioning? The schizophrenic. So if we're looking at functioning, then looking at the question might clue you one way or another. Another way to differentiate this is look at the delusion itself, okay? If the question mentions something about suspects, and the question meant something where I know that it's a fact, that's how you differentiate. The person who has the paranoid personality will say, you know what, I think my wife is cheating on me. I'm not sure, but I really suspect it. I haven't caught her, but I believe that it's happening. The delusional disorder will never use the word I suspect. They will use the word I know that this is happening. I don't need proof, but I know that it's happening. So it's different between think and is. Exactly. That's a good way of saying it. So that's what I want you to look in the question. So go back to the question. Does the patient believe it's a fact? Then you know it's delusion. If the patient is, I'm not sure, then you think it's paranoid. Okay? And schizophrenic, it's probably going to be, my wife is cheating on me with a space monkey. Okay? Then, well, yeah, you definitely are schizophrenic. Do you see the difference between these three things? All right. I think we are done with this chapter. Yep, that's it. So why don't we go on a break here, and I will see you in 10. Okay. Hello, everybody. Are we all okay? Can everybody see me and hear me? All right. So we're done with the psychotic disorders. And we're going to begin with the anxiety disorders, which, what do you think? High yield or not high yield? Very high yield, exactly. What they did in DSM-5 is that they totally changed the anxiety disorder chapters and pulled things out and put them in other chapters. For example, there's a trauma chapter now, or a trauma category, so PTSD got pulled out of there. OCD, there's an OCD category, so OCD got pulled out of there. So even though they're in different categories in DSM, they're still considered anxiety, so we're still going to include them here. So what do we need to know? We know that this is probably, ooh, no, we need something bright. This is the disorders, and that's why it's going to be super, super high yield. When we think of anxiety disorders, the typical patient is going to be young. She's going to be, of course, a female, and there's usually some sort of genetic loading. So either someone in her family probably has the same disorder. When we think of anxiety, you've got to think of anxiety as a syndrome. So these are people that have both psychological as well as physiological components. The psychological component is those fears of apprehension and worry, like you know that something terrible is about to happen. How many of you out there like to ride roller coasters? Where are the roller coaster lovers? I hate them. So when you are on a roller coaster, right? And you know that it goes ch-ch-ch-ch, the roller coaster starts going up, right? And then it stops. How do you feel when you are right there? That sensation like OMG, WTF, WTH, something is about to happen, and then it goes boom. But that sensation that you have at the very top, like you know what's about to happen, that is the psychological component, that fear, that inside voice that's telling you, oh my God, that's what's going on. The physiological components is what you feel. So how is your heart rate? How's your blood pressure? How's your respiratory rate? That's what anxiety disorder is all about. And every single one of these disorders will have both the psychological as well as these physiological components. So let's go back here. I can't stand roller coasters. Now I remember years ago I was teaching in California, and the people from the California office told me I should go to Universal, and then they told me the first thing you need to ride is the dinosaur thing. What's it called? Oh my God, my memory is terrible. Well, the ride with the dinosaur with the movie. Oh my goodness, what's the name of it? What they failed to mention, Jurassic Park, thank you. What they failed to mention that it was a little bit of a roller coaster ride. And I'm enjoying the thing, and then towards the very end, it starts going up, and I'm saying, oh my God, and then it goes back to a splash. Oh, I was not happy, I'll tell you that. I'm still traumatized by that. So let's go here. What do we know? For you to have, let's see what's happening with this slide here. These are the theories. Let's change that, because that's not what that is. These are theories of anxiety. One is Freud believed that if you don't let the instinct, your id, do what it wants to do, you're going to have anxiety. You are never going to see that on a question, okay? The other one is based on classic conditioning. And where do we see classic conditioning? In phobias. So you're 4 years old, you get bitten by a little rabbit. Now as an adult, can you be afraid of all animals? Yes. So that's classic conditioning. Now, when we think of neurotransmitter theories, then we know that people who have anxiety tend to have problems with norepi, problems with serotonin, and problems with GABA. So now you understand why antidepressants and benzos are used in the treatment of anxiety disorders. Okay, so one or the other are going to be the treatments. Let's start with the basic disorders. There are going to be 5 in this chapter, but remember what I told you. In DSM-5, some of them got pulled out of anxiety, and they're in different sections, but the diagnoses themselves have stayed the same. So let's start with panic disorder. For you to have the panic disorder, you need to have a series of panic attacks. So you need to have 3 or more in a 3-week period and worry about having more attacks. That's what that is. So for you to have the panic disorder, you got to have a whole bunch of them in an amount of time, and you worry about having more. You're going to see more of it in women, and remember, it's still going to be very young. So young women are more likely to get panic disorders. Let's go to the whiteboard. There's 2 things I want you to focus on. One is the panic attack, and the other one is the panic disorder. And the reason this is important is because the treatment is going to be very different. When you are in the panic attack, remember, your heart rate is going to be elevated. Your blood pressure is going to be elevated. Your respiratory rate is going to be elevated. So you're hyperventilating, you're sweating, you are thinking that you're going to die. That's the panic attack. So what we need to give you is a medication that works quickly. When you compare antidepressants and benzodiazepines, which are the ones that work quickly? The benzos are the treatment, the benzos are the treatment for these disorders. Now, which benzos can we use? We can use lorazepam, which is the one that's typically used in the ER, which is Ativan. We can use alprazolam, which is Xanax, or we can use clonazepam, which is Klonopin. But remember, any benzo is doable. However, on the exam, it will probably be one of these that will be present. So if they're being super nice to you, they're only going to give you one benzo. If they're not being nice to you, what they'll probably do is that they're going to give you 2 benzos, and you have to pick one versus the other. So how does this work? What we're going to focus on are 2 different things. We're going to focus on addiction potential, and we're going to focus on medical issues. So what do I mean by that? If you have a patient who's got panic and has liver disease, and if you have a patient who has a panic attack and you worry about addiction, the treatment will be different. Why? Let's go to a clean board. When you have patients who have liver disease, we know that there are benzos that are safer. And those are, remember, outside the liver. O was oxazepam. T was temazepam. And L is lorazepam. So if I'm giving you a 30-year-old male who's in a panic attack, right? And he has liver disease, then I could make you choose between alprazolam and I could make you choose between lorazepam. Which one do you think would be the best answer for that individual who has a pickled liver already? Then for that person, you would pick lorazepam. Does that make sense to everybody? So if they're making you pick 2, because the person's liver is gone, you want to pick the one that's less likely to affect it. All right. But when we worry about addiction, when we worry about abuse, what concerns us then is the half-life. So when we want to give a drug, so if you have a patient who is 24, has a history of abuse, and has a heart rate of 120, has a respiratory rate of 26, has a blood pressure of 140 over 1, is diaphoretic, and thinks that he's going to die, then I could give you lorazepam, or I could give you clonazepam. What do you think would be better for that individual? What do we know about half-life? The longer the half-life, the less likely you'll become addicted. The shorter the half-life, the more likely that you will become addicted. So clonazepam has a longer half-life. So when you suspect someone could become addicted, then pick the drug with the longest half-life. Make sense? So if I go back to the original page, when it's an issue of abuse, clonazepam is the answer. When it's an issue of safety for the liver, then lorazepam becomes the answer. So these are the only two times that they could possibly give you that you would pick one drug versus the other. You know, I remember when I took my Step 3 exam, which was probably 100 years ago, there's still one question that I remember vividly, and it was a patient who was in alcohol withdrawal, and the choices that they gave me were chlordiazepoxide and lorazepam. And of course, the patient had problems with his liver. What would have been the best answer? Chlordiazepoxide or lorazepam? You pick lorazepam, exactly. So they could do exactly the same thing here. When they're giving you the question of panic disorder, what the question will typically be is a story. What do I mean by a story? You know, doc, so the patient will come in and say, look, for the last 7 months, this has been happening to me. Every once in a while, I'm driving, I'm reading a book, I'm sitting on the beach, I'm taking a shower, and all of a sudden I get hit with these feelings that something terrible is about to happen. I feel like I'm about to die. I start to sweat. I start to tingle. My mouth gets dry. I get dizzy. And that's been happening to me for the last several months. So that's what the story is about. So the way we treat that is going to be with what? With an antidepressant, right? So we could give you a TCA. We could give you an MAOI. Or we could give you an SSRI. But based on the side effect profile, which one do we pick? We're going to pick the SSRIs. So you pick an SSRI as a treatment for panic disorder. How do we treat panic in the real world? What we do in the real world is that we typically will start the patient on an SSRI and a benzo. So we're going to give you both. Once we control the panic attacks, we keep you on the SSRI, and we then start to lower the benzo. Once you're stable, then we keep you on the SSRI. So long-term is going to be the SSRI as the treatment of choice and not the benzo. Why do we not use a benzo for panic disorder? Because we never know when the attack is going to occur. So remember, these attacks occur out of the blue, meaning I never know when it could happen. I could have one tomorrow, or I could have one 6 months from now. So because of that, I'm not going to give the patient benzos daily since they don't know when it's going to be. So that's why the SSRI is a better treatment option. Does that make sense? All right, so are we clear on the difference between panic attack and panic disorder? Here's what they do to mess you up. they're going to tell you that everybody in that patient's family died of heart disease. That's there to confuse you, because the patients who have panic, whether it's the attack or the disorder, believe that they're having a heart attack. So they end up in the ER. So you have to do cardiac workup. So you have to do EKGs, etc. So typically the attacks are out of the blue. Remember that. And out of the blue means there's no stressor, usually. So do you feel comfortable treating panic and the differences between the two? All right, let's move on. Then we have phobias, and the definition of a phobia, let me get my color here, hold on. The definition of a phobia is the irrational fear of either an object or a situation and the need to avoid it. That's what phobias are. So not only are you afraid of certain things, but you do everything humanly possible to not come in contact with that one thing that you are afraid of. And if you do come in contact with that one thing that you are afraid of, what typically happens is that you have massive amounts of anxiety. When you are afraid of things, it is called a specific phobia. When you are afraid of situations, it is called a social phobia, all right? So if I'm afraid of dogs, heights, water, head things, that's specific phobia. If I'm afraid to go out because I'm afraid something embarrassing or humiliating may happen to me, then that's what's called the social phobia. So let's talk about treatments. Let me go to the whiteboards. Give me 1 second. Let me get some color here. Give me 1 minute. Yeah. It's either specific or social. Why are we afraid of heights? Why are we afraid of dogs? Why are we afraid of mugs? Why are we afraid of elevators? Because what probably happened is that we learned to be afraid of those situations. Maybe something happened in an elevator when I was 4, and now I'm afraid of the elevator. So what we try to do, if it's learned, then how do you think the treatment is? The treatment will be to unlearn it, right? And how do we unlearn something? We use behavioral modification. And there's various techniques that we can use, so let's review those. There are several techniques, and you've got them in your notes. One is systematic desensitization. You have flooding. You have exposure. So these are 3 possible techniques that can work. Systematic desensitization works the following way. What we're trying to do is replace the anxiety with relaxation, okay? So you're going to come up with a list and you're going to of the things that make you anxious, and you're going to go from the least anxiety to the most anxiety. And we're going to use relaxation techniques. So if I'm afraid of heights, I'm going to come up with a list of what would give me anxiety. So maybe seeing a picture of a building, maybe going and standing outside of a building, then being in the building, then being on the top floor of the building. So when you compare the first one to the last one, the anxiety is getting larger. So what we do is that if I see a picture of a building, what's going to happen? I'm going to get anxious. My heart's going to go fast. I'm going to start sweating. My hands are going to shake. I then will do relaxation techniques, whether it's breathing, whether it's guided imagery, whatever works for you. If it works, what's going to happen to my anxiety? It's gone. I then move on to the next level, and I move on to the next level and the next level. That's systematic desensitization. Flooding is just massive exposure. And if you've seen the show Fear Factor, that's what flooding is. So if I have a fear of water, I get thrown into the Atlantic Ocean. If I have a fear of heights, I get taken to the Empire State Building to the top floor. That's flooding. It's massive exposure. And just exposure is just gradual exposure. I'm going to be exposed little by little to what I'm afraid of. So if, let's say, implosion is the same thing as flooding, but flooding is real and implosion is imagined. That's the difference. If I'm actually doing it, it's flooding. If I'm imagining it, it's implosion. Does that make sense? Okay. So exposure, if I have agoraphobia and I don't go out, then I might have exposure therapy. So the first day I open the door, I close it. The second day I open the door, I take one step out and I come back inside the house. The third day I open the door, I take 2 steps out and I come back. So very gradually I'm being exposed. Will they ever give you 1, 2, and 3 as choices and make you pick one? No. One of them will be there, you pick it, and you work with it. Usually systematic desensitization works very well, but they all work equally well, okay? Does that make sense? And you show a picture of a spider, then a glass? Yes, that would be exposure. So for specific phobias, then you use behavioral mod. For social phobias, the treatment's going to be different. It's going to be an SSRI. So you give them an SSRI, you give them a drug, and the drug is what's going to help them feel comfortable in certain situations. Now there's an offshoot of social phobia, which is called stage fright. It's also called performance anxiety. And this one, you'd give a beta blocker. And you give a beta blocker like half an hour to an hour before the event. If I have to give a speech and I'm holding the paper, my hands are going to shake. So what I do is that I take the beta blocker, my anxiety is under control. Yes, you take it before. You take it before the event. Like half to 1 hour before. Propranolol would be perfect. And you give them tiny doses, 10 milligrams or 20 milligrams. That would be perfect. So do you understand the differences between this one and how to treat both? Yes or no? When does the effect wear off? Relatively quickly. All right. So let's go back to the slides. Obsessive compulsive disorder in DSM-5 was removed from the anxiety disorder chapter, and it's in a chapter of its own, the obsessive compulsive chapter. So what is an obsessive compulsive disorder, or OCD? OCD is a patient who either has obsessions alone or has compulsions alone or has a combination of obsessions and compulsions. How do we choose between different behavioral therapy? I mean, they're all the same, so it's whatever you and the patient can agree on. Assertiveness training is to teach you to be more assertive, more secure of yourself. It's not something that you really would be doing with phobias as the treatment of choice. Usually you want to do behavioral mod. So what is an obsession? An obsession is nothing more. Did you understand that? An obsession is nothing more than a thought, which is repetitive, intrusive, and senseless. So now you have thoughts all day that you can't control. You know that you don't really want to do that, but you can't stop yourself. So what happens? Anxiety goes up. So how does the brain fix it? The brain fixes it by creating an act, something that you do in a ritualistic manner, which is also repetitive, which is also time consuming. And what that does is that it reduces the anxiety. So for example, if you think you've gotten dirty, that makes you nervous. So what do? You wash your hands. If you think you left the stove on and the house is going to burn, that's going to give you anxiety. So what do? You check the stove. That is what the obsessive compulsive disorder is all about. Now, what makes it a disorder is the fact that you lose your level of functioning. All of us probably have a little bit of OCD. I'm sure some of you out there will go to the bathroom and not touch the faucets. Some of you out there, how many of you do that? Exactly. Some of you will check things periodically. For those of you that have cars and have car alarms that you click once and you walk away, how many of you out there click once, you hear the alarm, and you walk away? How many of you have the ability to do that? One click, that's it. How many of you click several times as you're walking away? I mean, I know I do that. How many of you even put it on your head so it transmits farther away? So, right, yes, you can put it on your head and the transmission goes farther. Someone taught me that and it actually works. All right, good. Yeah, we're all a sick little bunch, right? So we all have a little bit of this. What makes it a disorder is that it affects your level of functioning. The people who have OCD have something called, it's ego dystonic, which means check the stove. They hate the fact that they have to do something repeatedly, so they're not okay with it. OCD is linked to serotonin. So how do you think we treat OCD? With SSRIs, okay? So clomipramine is not used. SSRIs are the treatment of choice for OCD. Why do we use SSRIs? Because they're cleaner. They're cleaner than a TCA. All right. Let me go over something that's not here. In DSM-5, do all of you know what hoarding is? Hoarding. Hoarding has always been a type of OCD. When DSM-5 came about, they put it out of OCD and it has its own category. So in DSM-5, there's something called the hoarding disorder. And because it's like OCD, what neurotransmitter is it linked to? Serotonin. How do we treat it? With an SSRI. Okay, so hoarding is where you say things and you never throw them away. That's the hoarder. So I'm walking down the street and I find a pencil that might not work, but I'm going to take it because maybe it's going to work. I find a box that's empty and I'm going to take it because you never know when I might need a box. I find a baggie that hasn't been used. I'm going to take it home. Why? Because I never know when I might need a baggie. That is hoarding. So there is the hoarding disorder. Understand that it's in its own category. You treat it with an SSRI. Oh yeah, those people that are, how serious is it? It could be very serious. Where basically, remember, your functioning is affected. Because of the hoarding, you're not functioning. And a lot of these people end up getting trapped in their house. They can't function. They can't cook. Their bedroom is full of crap. They can't sleep on the bed. They're sleeping in a chair somewhere. That's what it is. Okay? And it's also ego dystonic, yes. Yes, and it's a program on A&E. It's horrible to people live. And what's really sad is when they have kids, and the kids are growing up like that. Like, ugh. Keeping all receipts and papers can be signs. It all depends how many receipts and papers you have. Okay. I think for taxes, you're only supposed to keep things for like 7 years. But if you have things for 100 years, you got a problem. Then we have, let me go here, PTSD and ASD. PTSD and ASD got removed from the anxiety disorders, and there's a category now which is called trauma-related, and PTSD and ASD went there. So these are individuals who've been exposed to a stressor. Now this stressor is severe enough where you think your life is in danger, you think something horrible is going to happen, you think you're going to die. What kind of stressors are we going to talk about? War, right? Rape, tornadoes, tsunamis, earthquakes, floods. Like the people from all the events that have been happening in the world because of nature, those could be things for PTSD. People that are coming back from the war, people that survived 9/11, these are the types of things that you find. What's important about PTSD, ASD is that you look at the duration of the symptoms. If the symptoms are less than a month, you call it acute stress disorder. If the symptoms are more than a month, then you're going to call it post-traumatic stress disorder. Typically, acute stress occurs right away and cannot occur for more than, and by 30 days, it has to occur within 1 month, and then it doesn't go on for more than a month. PTSD can occur at any time, and the symptoms are usually lasting more than 1 month. For you to be diagnosed with PTSD or ASD, I want you to focus on one of the key symptoms is re-experiencing of the symptoms. So you're going to have nightmares, you're going to have flashbacks, you're going to have something called phobic avoidance, you're going to have sleep problems, you're going to have mood problems, you're going to have increased startle reflex, so you scare very easily, you're going to be hyper vigilant, so you're constantly looking around the room to make sure that you're safe. You're going to feel guilty about surviving. Like, it's very common for people to come back and their friend got blown up. They feel bad because they survived. That's something called survivor's guilt. So I'm sure you could see it now, what's going on in Syria, what's going on in, Venezuela, what's going on in a lot of these countries. Ukraine, all of these people could definitely experience PTSD. The treatment for PTSD is going to be SSRIs. And that's how we treat it, okay? So please remember, let me go to the whiteboard. And get the whiteboard. For PTSD to be the answer, let me get some color here, hold on. For PTSD, even though I told you that the symptoms are for more than 1 month, you don't need time on the test. However, for ASD to be there, time is essential. So it's very important. So if they tell you a woman was raped and now she's got nightmares, flashbacks, and stopped going to work, what's her diagnosis? PTSD. Time does not have to be mentioned. For ASD, then yes. We treat anxiety with SSRIs. Research has shown that long-term use of benzos are not helpful. Benzos should only be used for short times. However, in the real world, how many people with anxiety disorders stay on benzos for the rest of their lives? Probably a whole bunch of them. But theoretically, that should not happen. The best medicine is to take them off the benzo and keep them on the SSRI. All right, make sense? So any questions on PTSD or ASD? All right. And then the last one is generalized anxiety disorder. So this is an individual who has symptoms of anxiety, but what I want you to focus on is the word worry. So these are people who basically worry about things they don't have to worry about. Like their house is secure, they worry about that. Their finances are secure, they worry about that. And it's been going on for more than 6 months. They can't relax, they can't concentrate, they have problems with sleep, they could be irritable, and the way we treat it will either be with an SSRI or a buspirone. Both have FDA approval. I cannot imagine that they would give you both. So it will either be one or the other. All right, so this is a milder form of anxiety where you just worry all of the time. And it's happening for more than 6 months. So if you worry about losing your job and your house is in foreclosure, do you have generalized anxiety disorder? No, you should worry. Because if your house is in foreclosure, that gives you reason to worry. This is not GAD. GAD is just that person that can't relax, cannot enjoy themselves because their mind is always going and going, thinking about what could happen. I'm sure a lot of you might have this. I'm sure a lot of our parents would have this. This is, well, worrying for USMLEs, you should worry. Definitely worry. So any questions on anxiety? Okay, we're done with this chapter. So any questions before we go on our break? Why buspirone? Because they believe that buspirone works on serotonin and it has FDA approval for the treatment of GAD. That's why. But as a psychiatrist, you know we're going to pick SSRIs before we pick buspirone. But they both work. So I cannot imagine they'd make you pick one. Only use benzos for panic attacks. So any questions on anxiety? All right. So I think this is our, okay. Have been while surviving the event and then later suffering. Is it more common to have while surviving the event and then later suffer symptoms? I don't understand. Is it common to have, by MIN, do you mean minimal symptoms? You tend to have more symptoms after than before. So while you're doing it, while you're in the trauma, your symptoms are not as bad as after, because after then it's prolonged. That is correct, yes. All right, so let's go on our hour break here, and I will see you in 1 hour, because we break here, right? All right, so I'll see you